The following podcast is part of a certified educational activity titled The Earlier the Better Multispecialty Guidance on Screening, Diagnosis, and Management of Resectable Non-Small Cell Lung Cancer. Access the entire activity and complete the post-test at peerview.com/JYH860. Downloadable slides and practice aids are also available.
Well, hello, colleagues, and welcome to this educational session entitled The Earlier the Better, a multidisciplinary and multi-specialty guidance on screening, diagnosis, and management of operable or resectable non-small cell lung cancer, a key hot topic for how we manage our patients with early lung cancer that we see in the clinic today. My name is Sanjay Popat. I'm a consultant medical oncologist at the Royal Marsden Hospital in London, and I'm joined by two renowned world-class experts. My first colleague that will be joining me is Professor Joachim Ertz, who's a pulmonologist, respiratory physician, and oncologist at the Erasmus NC Cancer Institute in Rotterdam in the Netherlands, and my expert colleague as well, Professor Solange Peters, who's chair and professor of medical oncology at the University Hospital Lausanne in Switzerland. So what are we going to be discussing today? We're going to be talking about the current recommendations and our experience with lung cancer screening across Europe and the UK, a very important topic. We're going to equip all of you with the skills to evaluate, diagnose, and develop the appropriate treatment plans for patients presenting with operable stage 1 to 3 non-small cell lung cancer, and to allow you to better understand the role of immune checkpoint inhibitors or immunotherapy-based strategies into how we manage our patients today. So first of all, we're going to hand over to Professor Ertz, who's going to speak to us all about screening. Joachim, take it away.
Well, thank you, Sanjay. I'm more than happy to present the data on lung cancer screenings. Lung cancer is an enormous problem in Europe, and you can see that almost 500,000 people are diagnosed with lung cancer, and lung cancer accounts for about 20% of all deaths of cancer in Europe. And the reason for this is that most patients are diagnosed in the advanced stage. So they are diagnosed in stage 3 or stage 4 disease. And when you look into the survival, depending on what stage of lung cancer people are, the survival is decreasing. So in stage 4, it's only 10%, while in stage 1, it rises up to 92%. And in stage 2, it's 67%. But it is even getting better, as you will hear from Solange later on in this webinar. What we can see with lung cancer screening is that when we apply lung cancer screening to patients, heavily smokers, that there is a stage shift, and that we now are diagnosing more people in stage 1 than in stage 4. And that ultimately leads into a lung cancer mortality reduction of at least 20%. And where do we stand with lung cancer screening in the EU? Well, the EU has updated a recommendation to include lung cancer screening with low-dose CT, and it's a stepwise approach, so meaning that depending on the country, depending on how local healthcare systems are working, that how to implement lung cancer screening. It's looking at feasibility and effectiveness, and for now, we look at high-risk individuals, which are called heavy smokers or ex-smokers who have smoked heavily. For the UK, it's somewhat similar in the sense that they also do look at low-dose CT screening, people high risk with the age of 55 to 74. But also in the UK, there's the integration of a smoking cessation clinic and also a more targeted lung health check. And I will come back to that later. So when we look at the implementation of lung cancer screening around Europe, well, there is no unified guidelines for lung cancer screening, and the ERS and the European Society for Radiology have published a technical standard on how to integrate lung cancer screening, and they also have made a statement on what to do with incidental findings, which are found with low-dose CT screening, like, for instance, breast abnormalities or coronary calcification. There's also a working group which is called SOLACE, which can help countries how to develop and test and disseminate tools to overcome the bottlenecks in lung cancer screening, and how to specifically, depending on local situations, apply lung cancer screening most efficaciously. When we look at the lessons we have learned from lung cancer screening implementations, I will only focus on 4 main lessons. And one is to tailor the eligibility criteria from screening to reach those at highest risk for lung cancer. And for now, that is, of course, looking at smoking, but we hope to adapt the eligibility criteria to optimize risk prediction models and optimize the use of biomarkers. So, for instance, in the US, there was an adjusting of the guidelines to expand this eligibility and improve equity of screening, for instance, to get more people from African American into the screening programs. But the other way around is also looking in China, there's an increased risk of lung cancer for tin miners, and those people should also get access to lung cancer screening. Because in Central, we look at tobacco smoking, but we know now there are far more risk factors to get lung cancer. So one is what we all know is, for instance, in social, environmental, looking at secondhand smoking, but it's also the environmental exposure, for instance, to radon. And what we have learned more and more about is the air pollution. There's the occupational exposure, so asbestos, which also increases the risk for lung cancer. Infectious diseases like tuberculosis, chronic inflammation like patients with COPD have a higher risk of getting lung cancer, and also those personal characteristics like sex and gender, age, and family history. And all these should be taken into account in risk models to get most effectiveness of lung cancer screening, just separate also from only looking at smoking. The second lesson is to develop targeted outreach to address potential barriers for the participation in lung cancer screening. So we have to understand the barrier to screening attendance. Ensure the screening program is geographically appropriate. So for instance, that people can reach the screening centers and engage those high-risk individuals. And in the UK, that has been done by overcoming informational barriers and stigma by presenting screening as a lung health check. You can imagine the stigma that people get when you call it lung cancer screening, and it's different when you say you get a lung health check. And in New Zealand, they have learned lessons on how to engage marginalized communities for other cancer screening programs. So there's a lot to learn from other countries, how we can get access, how people can get more access to lung cancer screening. When we look at lesson 3, it's to amplify the impact of lung cancer screening by integrating into other public health initiatives. So for instance, integrate the smoking cessation program into the screening, or combine it with other screening programs, like for instance, breast cancer screening, and try to detect other diseases. In France, there is now this already part of lung cancer screening where they are detecting other diseases. So other diseases like coronary calcification, like emphysema, like breast cancer, that it can be done by this low-dose CT screening. In Sweden, there is an engaging lung cancer screening woman involved in other screening programs. As I told, for instance, you can also apply lung cancer screening to patients having breast cancer screening. The last lesson to be learned is to ensure the full integration of lung cancer screening into the health system. So you should ensure that it's adaptable to local context and health system, invest in multidisciplinary care, and take a comprehensive approach to planning. So one of the things, of course, happening when we get more people diagnosed with a nodule, that there needs to be space in the healthcare system that those patients are looked after. So in Croatia, there's an accelerating waiting list for specialist care to avoid bottlenecks in the care pattern. And in the US, there's a creating of screening centers of excellence. So you can imagine that when all those nodules who are detected do not have all need to get a proper follow-up. Some can be called benign, and that needs centers of excellence who can decide on that. And that will help to minimize the load on the healthcare system. And with that, I will hand over to Sanjay for the discussion. Oh.
Thank you very much. So, Joachim, you've highlighted the benefits of screening. Just give us an overview about where we are with screening in Europe. I mean, in the UK, we've got a very active program. I'm not sure what the current status is in the Netherlands, and have you in the Netherlands overcome some of the barriers to access?
So for in the Netherlands, there's no active screening program yet. We're still thinking about it, but it's not implemented, which is of course a great pity, looking at the burden on our patients. I mean, Germany has now implemented lung cancer screening. They are starting off. Italy, and more countries are getting lung cancer screening now already going, but it's still, yeah, as it is in the EU, it's always the decision of all the individual countries. And for the Netherlands, the problem is there's still a debate whether, for instance, the lung cancer mortality reduction and the discussion about all cause mortality reduction, um, and well, it's of course, yeah. We hope that we can implement it as soon as possible, but for now we're still on waiting.
And Solange, in Switzerland, you have a program set up, or not quite yet?
It's very interesting, and I have heard that we had to face the same requirements that many other European countries was to reproduce. The requirements were to reproduce the data produced by the NLST, so I would say the best screening trial in the context of the country. The idea is to show the feasibility of identifying these patients because tobacco usage, for example, is not very well documented. It's not centralized. So you need really, like Joachim was telling, to embark with you the GPs because they are the ones to potentially be able to identify this patient, but also to embark the whole population for conveying the message and promoting this kind of screening. And thereafter, we had to show that the quality of all the, I would say, false positive and the management of undue biopsies, complication, as well as a more or less 2% finding of lung cancer would be also reproduced in the same environment with the same risk factor. We did it. And we did in Lausanne, by the way. We did this very early pilot trial, which was recruiting extremely fast. So it's interesting because it was also a lung check, also with some pulmonary function and general functionality assessment and advice in smoking cessation too. And it worked very fast and very well, meaning that at least in Switzerland, there is this health concern and heavy smoker patients, not so sure they quit smoking, but at least they'd like to know about the health of their lung. And as much as we have seen, we reach the same number of false positive, real positive cases and complication very similar to NLST. What I find very interesting to think about also is this incidence rising of never smoker lung cancer patients and what has been produced, for example, in Taiwan and now in Japan and Hong Kong, where potentially in other geographies, due to genetics, but also due to the environment, we might start to screen dedicated group of patients who have not smoked. So I think we are just moving for the smokers, and we will need to embark maybe at some point in considering family history or maybe where you come from and your genetics behind in order to extend that. So we are a bit late and we should accelerate the process, to my opinion.
Thank you very much, Solange. There are many things here that we have to think about when we're implementing screening. But the key message that we've heard is that screening reduces mortality, and that is the key take-home message. And the ERS has clearly highlighted that this is important, and our countries really do need to ensure that we can implement screening at national levels. Now, I wanted to discuss a case. So this is a 59-year-old male. He had smoked with a 20 pack year history and was invited for a screening lung health check. He attended the car park CT mobile unit, had a CT scan, and that was actually abnormal. And in May 2023, it reported an area of ground glass opacification without a solid center with measuring around 7 millimeters. He went on to a further surveillance CT scan 1 year later, which showed that that ground glass area had started to solidify with more of a solid nodule, looking more suspicious. There was no adenopathy. Underwent a PET scan, showed no distant disease with some, modest uptake in the area of solidity within the ground glass nodule, which by February 24 had measured 9 millimeters. So we're quite concerned about this particular case. How would you have managed this case, Joachim, in your particular practice?
Yeah, I think as you were also saying, I think certainly because of the FDG avidity and the fact that this is a nodule which increases in size, I think we would be really aggressive on such a case.
Yeah, thanks. And Solange, in this sort of case where you have what looks like a high risk lesion which is maturing, would you go for biopsy or straight to surgical resection in your center?
It's interesting because, of course, you took the gray zone nodule, right? Would this nodule be 3 millimeter? You would have had to follow it later on, right? But the 9 millimeter, it's above the 8 with the Fleischner kind of criteria we use. We have a nodule board. Interesting to say. We have a tumor board, not a tumor board, a nodule board, because they are not all tumors. And the nodule board will probably have said PET-CT. If PET-CT is avid, resection. The problem of a biopsy, when you have this 9 millimeter and a PET which is positive or slightly positive, is if the biopsy is negative, you are not comfortable, you'd like to resect. If it's positive, you would like to resect. So if at the end you would like to resect, maybe we gain some time and we go there. So for such nodule, I think we would have gone for a resection and probably some simultaneous examination so that we know how much it's useful or not to sample the lymph nodes in that circumstances. But I think we would have gone for resection.
Thank you. So let's move on to talk about staging. I'm going to talk to you about how we should be staging our patients in the clinic. So if we look at the ESMO recommendations for diagnosis and staging for early lung cancer, we have a set of investigations which are mandatory and some are optional. Clearly, medical history, physical examination is important, and all of these patients should have a contrast-enhanced CT of the thorax and upper abdomen. Patients should also have a PET-CT scan and MRI brain to make sure they don't have any distant metastatic disease, recognizing that PET-CT is not adequate really by itself to tell us about information about lymph nodes because the high risk of false positives and false negatives, which may influence our decision making. Of course, patients should have appropriate blood work and then some form of cardiopulmonary function. They should clearly have some form of lung function test to ensure they have adequate lung function to undergo some sort of radical procedure such as surgery or even SBRT for some patients if they're not fit for surgery. And different centers vary by if they have invasive monitoring such as CPET or CPEX, or simply in some centers they ask the patients to walk down the corridors or up the stairs to see how breathless they get. There is a debate about biopsy for the very, very small lesions, but in general, some sort of tissue biopsy is indicated for the vast majority of lesions that we pick up when the risk is appropriate. And that can be done through a number of different mechanisms. And certainly if there is any hint of nodes being involved, these should be sampled, ideally by endobronchial ultrasound or the bronchoscopy version of that through the esophagus EUSB. You may consider a mediastinoscopy, although that's not performed much these days. The specimen, after a full evaluation, should also undergo molecular testing, at the very least with EGFR and ALK, and ideally with PD-L1 as well to help the decision making moving forward. If we look at the ESMO staging algorithm, it's very much bifurcated by whether there are lymph nodes identified that are positive or negative on imaging. And if lymph nodes are positive on imaging, they should be sampled and confirmed, ideally through EBUS or EUSB, in a non-invasive method to confirm the nodal staging. And if you have a patient that's node negative, you may want to consider a tissue sampling of the mediastinal lymph nodes if it's a high-risk tumor, for example, a large tumor or a tumor that's close to the central airways. And we'll come back to talk about nodal staging in a while. Now, the biomarkers are really critically important here because the biomarkers, particularly the more advanced case that we have, it determines where we bring in systemic therapies. Do we bring them in preoperatively or postoperatively? And it helps us decide what we should be doing with the case. EGFR and ALK testing is really critical because our EGFR mutant cases and ALK fusion positive cases ideally should be going for consideration of upfront surgery and consideration of adjuvant TKI for those cases, contingent on the stage of the tumor. And in those patients that are wild type for EGFR and ALK, we really want to be thinking about the role of immunotherapy. Do we have immunotherapy before or after? And that determines our approach to the particular patient. And so it's important that our pathologists consider this, and we may want to do this testing at biopsy. I think all of us would recommend done on the biopsy, but if it can't be done on biopsy, there is another opportunity to do that on the tumor resection as well. So you can clearly see that this decision making that we have is multidisciplinary. We need to factor in so many people into the decision making. We have to factor in the patient's views, we have the respiratory physician's views, the surgeon's views, the bronchoscopist's view on how they can access this type of specimen, the pathologist's views on whether they have an adequate specimen for molecular testing, and also the lung function technician who performs this type of testing for lung function in the clinic. We have to think about whether the specimens are operable. Now, these are the review of consecutive cases that presented in Belgium and a roundtable consensus. There was a subsequent consensus which is not yet published, but this highlights that we clearly have cases which are not operable because the bulky N2, invasive N2. Clearly, you have cases that are operable, single N1 or N2 that are single, and we have a gray zone that people argue about, that may be operable or may not be operable. And I think we need some standardization or homogenization of the decision making in that setting. Often when we think about surgery, we have to consider, of course, the patient's wishes, their general health status, their tolerance of risk, and that often can be really quite variable between centers. We have to think about the surgical experience and their risk tolerance, and that again can be really quite variable. We have to think about the baseline physiology. Is the patient well enough to undergo resection? Are they well enough to undergo the magnitude of resection and have adequate lung function post-operatively as well to come through this without any complications? What is their predicted post-operative functional reserve? What is the probability of R0 resection? That is really critical, especially if we're going down the neoadjuvant route. And are they likely to undergo neoadjuvant therapy without any risk and get to surgery? Really critical that patients do not miss out on surgery, which is by far the most important thing for their treatment. And of course, weighing up all these risk benefits together. So you can see that this is a complex process. Many people factor into the decision making. We have to think about integrating all our decisions into this and coming to a conclusion with an MDT after the final stage and deciding what the best options for our patients are. So I'm going to come back to this case actually. So the patient then had the nodule, it's 9 millimeters. They had a further PET scan, which showed that the nodule was avid with an SUV of 2.4. And there was enlarged paratracheal lymph node, which was also avid, a station 4L lymph node, which was avid in this scenario. EBUS was performed. The station 4L was sampled. It was positive. The contralateral station 2 and station 4, R2 and R4 nodes were sampled. They were negative. So we have station 4 positive for adenocarcinoma, TTF1 positive, contralateral nodes negative. NGS of that specimen demonstrates no actionable alterations, PD-L1 20%. Brain is negative, so I have a thick patient with a left upper lobe tumor, T1, B, N2, with single station, station 4. How are we going to manage this patient? Well, we're going to talk about our options, but just in terms of staging, I'll bring in Solange to this question. How would you stage that in your center? Would the patient also had EBUS, or do you go to an invasive procedure such as mediastinoscopy? Do you bother biopsying the primary if you already have lymph nodes that are positive, or do you think about robotic biopsies, etc.? Solange, your thoughts on that?
Thanks for the question. I remember the old debate about sensitivity and specificity of EBUS versus mediastinoscopy, but the minimally invasive techniques now have reached a point where mediastinoscopy is very rarely used. So I would say for us, it's an EBUS for sure. And we first go to the lymph nodes because it helps you to get two steps into one, right? If you find the tumor here, biopsying the primary with the risk of pneumothorax sometimes when it's peripheral and so on, it's really only, as I said before, if it changes the final decisions that you might take. And very often, if nodes are negative, it might not be the case. I would say, honestly, the only additional things that my pulmonologists like to do, particularly when the tumor is central, is to have a look at the bronchoscopy to see if there is any airway, I would say abnormality, which happens sometimes in situ modification, particularly in heavy smokers. So they like sometimes to have an eye on the bronchi epithelium, doing the EBUS, for example, but they like to have it. But it's not really in the guidelines. So I say EBUS, and sometimes no biopsy and resection if it's N0. In this case, EBUS is fine.
Yeah, thank you. And Joachim, I'll bring you in as well. Any changes for the Rotterdam approach to this type of case? You have a similar approach?
No, I think Solange did a great job as a pulmonologist, although there's no need for me to add. No, the only thing I can add is that we now as pulmonologists do have the navigation bronchoscopy in our options, and that helps to also get biopsies from small lesions. So as Solange is saying, when this was an N0 case, I mean, we haven't seen the pictures where the nodule is located, but sometimes you can get access to it by doing navigation bronchoscopy. And in our experience, this is really helpful, and that you can prevent sometimes from patients getting sampling via VATS or these kind of interventions.
Yeah, totally agree. The world with technology continues to move forward in that manner. So I'm going to hand over to our final speaker, Solange, and you're going to tell us about our options for drug therapy in this particular type of case. How should we move forward? Solange, over to you.
So the idea here is to try to understand particularly the role here of the systemic treatment part of the management. So of course, and this is just a very easy definition, the local therapy being surgery in our discussion, but also sometimes stereotactic radiation or definitive radiotherapy, in order to manage the visible part of the tumor and its lymph nodes. But what we always fear, and what happens unfortunately very often in lung cancer, is a distant relapse, a local or a distant relapse, meaning that micrometastases are present but not measurable and visible at the initial diagnosis. And for that, we've been moving from an efficient chemotherapy in the adjuvant setting or concurrent radiation, which of course improves survival long term, maybe 5% long term, but is efficient, to some more evolved strategies, including immunotherapy. And that has further improved the idea of treating micrometastases. And we will focus today again on the resectable piece of it, but we have very similar data with radiation being the backbone, but trying to see what you do around the surgical part of the management. So we have three definitions that we have to keep in mind because they are now pretty used. The neoadjuvant treatment, meaning that you concentrate the systemic treatment before surgery and everything is done at the time of surgery. The adjuvant treatment, very classical, you start with surgery and you complete depending on what you find at surgery. Or the perioperative, we can call it sandwich, but we don't really do it. We do it in sarcoma, but not here, meaning before and after, with very often the chemotherapy being here given before and some continuation targeted or immunotherapy later on. And we have data. We have data in these patients with early stage non-small cell lung cancer. Remember, it's 1 patient out of 4 having resectable disease, which is half of them. So all in all, 1 out of 8 non-small cell lung cancer patients enters this scheme, right? We have these cases where immunotherapy can be added. So that's what we have today. And I will just drive you through this neoadjuvant, perioperative or adjuvant treatment. And we, of course, will have the focus on immunotherapy, trying to select the appropriate patient for upfront strategy of surgery or not, understand the evidence, determine the best sequence of therapy, even if it's a kind of a religion and a gray zone at the time being, depending where you are, and trying to monitor the adverse event in a curative setting, of course. Staging was told about before. So we have this very classical tumor assessment, CT PET, EBUS if needed, mediastinoscopy rarely, but of course brain MRI, which in early disease is mandated. All the functional testing of the heart and the lung, as well as fragility of the patient. And if possible, particularly if you have an N+, meaning that you are in this perspective and consideration about neoadjuvant treatment, you need to know if you are facing an oncogene addiction. And basically today you need to know if you are facing EGFR and ALK, because in these patients there might be a better strategy than ignoring it. We also love to have the PDL1 because regulatory-wise it might change how you can prescribe, but also because it tells us a little bit what you expect from immunotherapy. So if you have an N+, and you consider neoadjuvant treatment, you need to have EGFR, ALK, and PDL1, and that's very chic if you can have NGS at that time, but sometimes it's not doable, okay? So thinking about immunotherapy, and this is about the pure neoadjuvant. Checkmate 816 was giving neoadjuvant treatment for patients with more than 4 centimeter tumor, and of course in the N plus tumor too, 3 cycles of chemo-nivolumab. The idea was to show an improvement in pathological complete response and an improvement in EFS. Both were reached with an amazing multiplication by 10 of pathological complete response, an amazing event-free survival. You can see the 3-year update that we have been seeing from 38 to 49% of disease-free, event-free survival. And the overall survival was improved also, which was shown recently at the ASCO meeting, published in the New England, with a quite impressive hazard ratio for survival of less than 0.8, 0.7. I have difficulty, 2.72. I would just remember 2 or 3, which is quite amazing in terms of what we have been expecting from is systemic treatment in the limited disease. What I mean by that is, remember I spoke about 5-year survival for chemo. So here we are in a range of magnitude of benefit, which is at least matching what we're expecting from the best treatment we had in the past. And of course, the lung cancer symptom also to be perfectly manageable. It's quite important to say. So when you avoid a relapse at the end, you improve the patient-related outcomes. So this is the pure neoadjuvant. It's difficult then to compare. It's important to say. These are amazing data, but this is the only trial with neoadjuvant only. And let me say, it's going to be probably the only one. So what I mean by that is whatever you do and you multiply differently and using different strategies will always be compared to this single trial. So be confident about what you decide, but also aware of the limited comparison which is possible. If I say that, is because we have trials piling up in China, in Europe, globally, with perioperative, the sandwich strategy. 3 to 4 cycles, usually 4, of chemo IO, followed by 1 year of IO. This is Agen on the left, which is using durvalumab in this strategy. On the right, this is Keynote 671 using pembrolizumab. And on the bottom is Checkmate 770 using, again, nivolumab, but perioperatively. What is important to tell here is the EFS benefit is again matched to a very significant effect as primary endpoint in all of these 3 trials. And the Keynote 671 is already reading an overall survival benefit across all subgroups of patients, probably slightly broader in terms of overall survival across subgroups than the one previously with only neoadjuvant. So a very transversal, horizontal effect across subgroups. The other 2 trials, Agen and Checkmate 770, are still waiting for the US data. As you can see on this curve, the censoring is extremely heavy, meaning that we wait a longer follow-up to be able to read it. We all expect and hope it will show a survival effect, but we need to wait for a long period of time. But basically, EFS and pathological complete response are really improved in that trials. Let's just look at the classical adjuvant. Adjuvant is not old-fashioned because in many countries and settings, the first thing and the first doctors the patient sees a surgeon for operational and organizational matters, right? And if it is the case, the surgeon might intervene first, and then you need to complete. So in the Empower 10, they had to complete with chemo, at least 1 cycle, and then 1 year of atezolizumab. There was a whole hierarchy of endpoint, but at the end, and this is maybe the US picture, the atezolizumab is registered in PD-1 positive patients with a stage 2 to 3 non-small cell lung cancer resected. And you can see here how the PFS and the overall survival have improved. It's only numerical for the overall survival, and it's important to say. In Europe, we go for more than 50% PD-L1 because the EMA wanted even a more important separation of the curve. On the right-hand side, this is the same trial, exactly, with pembrolizumab, and chemotherapy was optional. 1 patient out of 5 did not get chemotherapy. And you see exactly the same, I would say, EFS, DFS in the ITT population. But the design was made that it was reading positive for DFS across all subgroups, which make that pembrolizumab can be given in the adjuvant setting across the patient subgroups. But basically, let's be very honest, the results were very superimposable. But as you can see, the curves separate, but a bit less than the neoadjuvant strategy. Of course, you don't compare the same patients, be careful. You don't compare the same staging. One is clinical, one is pathological. But biologically and I would say scientifically, we all believe somehow that neoadjuvant is a good strategy. Good strategy because in terms of immunogenicity, you have a clonal tumor on site to mount an immune response, a patient who is fit, and you have an early potential eradication of micrometastatic disease. If you think about the adjuvant setting, it's also probably good because at least you avoid any surgical delay, any toxicity preventing surgery, and you are very rapidly relieving a patient for a very high anxiety too. You can customize the adjuvant treatment, but as you said before, we feel like the magnitude of what you get with immunotherapy is slightly lower than the neoadjuvant. And perioperative is a big question about how long and how much. So we like the perioperative strategy because it's maximizing the effect of immunotherapy. You can also use a surgical setting after neoadjuvant treating to customize your adjuvant part, but it's a question mark. We don't really know how to customize now. So is neoadjuvant sufficient? Do we prefer perioperative? In oncology, we tend to prefer more, particularly myself, but it's not completely and fully established. So I think the future will tell us a bit more about how much and how long, but I think it's an important question. So all of this we have to discuss in tumor board. Does your patient match a primary surgery? Or if N plus, maybe a neoadjuvant strategy, knowing that anyway, systemic treatment will be given. Does your patient match the immunotherapy component in terms of autoimmune disease, inflammatory lung disease, comorbidities, and that your patient match the biomarker assessment, EGFR, ALK? Because remember, in EGFR and in ALK, you have to give adjuvant TKI. So don't give neoadjuvant IO. This is not compatible. Let's go back to our patient. Our patient had surgery. Our patient had surgery because you remember they had this enlarged lymph node. The enlarged lymph node, which was presented by Sanjay, were unfortunately biopsies. So it's an N2, which we don't like, a stage 3. So, well, of course, with a positive PDL1, a brain MRI negative, it was discussed to go for surgery. But first, neoadjuvant or immediately surgery? We always give neoadjuvant, so we will have given neoadjuvant chemo IO. So that's what was done. Neoadjuvant chemo and immunotherapy, 4 cycles, and as you can see, an amazing CT scan which becomes almost normal with just a shadow at the primary site and the lymph nodes have disappeared. Of course, what is important is not what you see, is what you see at pathology. What pathologists tell you, it's a 0.8 remaining tumor with 3 lymph node positive, 1 being an N2 lymph node, no extracapsular invasion, meaning it's an R0, and still residual tumor, I would say, meaning it's not a complete pathological response. There is 10% of residual viable tumor. For final stage, why PT1, why PN2? So basically, the main question here, and it's going to be the topic of discussion, are you happy and you stop mimicking the checkmate 816? Or are you not happy and you continue for an additional year of treatment because of this residual lymph node positivity as well as tumor on site? For very good questions, I would continue for an additional year in that setting, but we must really admit that this is the main point of discussion today. So that's basically the case illustrating how much we can today consider immunotherapy and should, but also how much ongoing research is necessary in this patient. In terms of toxicity, let's keep in mind that we know very well the toxicity of immunotherapy. We know what immune-related adverse events represent, and we know how much sometimes they might prevent or not the continuation of treatment. Be aware of one thing. This toxicity very rarely of IO intervene before surgery. Toxicity of immunotherapy happens later on, but the chemo in neoadjuvant setting might have toxicity. So some of the patients have toxicity before surgery, but most of them present with the usual grade of immune-related toxicity at a later time point. We know how to manage them. We are all very skilled in that. So I would say no surprises there, but a caution to have, because remember, you are in the curative setting. So we have lots of guidelines. Yes, more guidelines. The CITSI guideline, which have just been updated, they guide you, but also your colleagues guide you. I don't think that is a major challenge today, but you have to keep an eye on your patient and tell him about it. So this is more or less what I had to tell about it. Maybe Sanjay, you take the takeaways, messages, and the questions to end up this debate. Thanks so much.
Thank you very much, Solange. Thank you for that fantastic overview. So we presented a case that had undergone screening, that had a nodule, that then had matured to a small biopsy-proven tumor. We had station 4 lymph nodes involved. I think you presented, Solange, the choices that we have: adjuvant, neoadjuvant, chemo-IO, perioperative management, very well there. Your view after the patient underwent neoadjuvant, still had residual 10%. You would give more immunotherapy. I'll bring Joachim in for his consideration. I have to say, in the UK, many people would stop after 3 cycles and not give anything more, as per 816. The Dutch view, Joachim, where would you have gone with that one?
Well, I'm with Solange, so I think I mean there is a response, and I would continue because, as we know, we don't know whether the patients are cured when they have a complete pathological response. That's what we think, but we don't know. We have to see the data. This patient still had residual disease, but there was some response, so I would continue. The problem is, and indeed, in the Netherlands, it's not reimbursed, so we have no option to give adjuvant after neoadjuvant. So we cannot give it. But when you ask me what would be my choice, my preference, I would definitely continue with the treatment.
And therein lies some of the issues that we see in this very complex and very interesting field of early operable lung cancer, right the way from screening. So the take-home messages are that lung cancer screening saves lives. Multidisciplinary collaboration is fundamental and key to improving survival. Biomarker testing is critical to decision making, and we must integrate immune checkpoint inhibitors when indicated to our patients to drive home that survival advantage. Thank you for listening. I do hope you found that useful. Thank you very much to my expert colleagues for joining me and our discussions and their presentations. And I look forward to seeing all of you again at another occasion. Thank you.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/JYH860.